Hello, and welcome to Common Health, a podcast brought to you by the Virginia Community Healthcare Association, where we discuss all things community health in the Commonwealth of Virginia, amplifying the voices of those who are served by community health centers here and those who serve them. My name is Kyle Elliott. I am the Chief Legal Officer and General Counsel for VCHA. I am your guest host today, filling in for the illustrious Tracy Douglas. I'm very excited about today's episode, which is focused on a fascinating topic, medication-assisted treatment for substance use disorders. I am pleased to introduce today's guest, Whitney Chase Petrie, Manager of the Addiction Treatment and Recovery Program at the Community Health Center of the New River Valley, and Dr. David Roberts, Chief Medical Officer of the Community Health Center for the New River Valley. Whitney and Dave, welcome.
Thanks for having us.
Well, thank you so much. Why don't you just tell us a little bit about the community you serve and the area in Virginia where you all are located?
Sure. We have three settings. The principal is in Christiansburg, Virginia. And then we have satellite locations in Parisburg in Giles County and in Dublin in Pulaski County.
Excellent. Well, I'm really excited to dig into this topic with you all today. Why don't we start with a little bit of terminology? I think a lot of people still think of different terminology when discussing the population receiving medication-assisted treatment. People often use terms like drug abuse or addiction, alcoholism. When did the industry kind of shift to the term substance use disorder, and why?
I think it's, there's a lot to the language that we choose to use and assigning labels as opposed to identifying conditions. And so I think the substance use disorder, first of all, can be applied to multiple different substances. And it's not as fraught. It doesn't sound as judgy to say someone has a substance use disorder as opposed to this person is an opioid addict or an alcoholic.
And there's certainly been a shift in terms of like the clinical or therapeutic community. I know it's often spoken that in 12-step communities, folks may refer to themselves as an addict. And that's certainly okay if our patients refer to themselves in that way. We just won't refer to our patients as an addict because they are a person living with a substance use disorder. They are not defined by their addiction or by that substance use disorder.
What are some of the most common substance use disorders that you all encounter and see in your practice?
The three that I think include all of our patients would either be opioids, things that take as a basis the kind of the poppy seed. And that's, things like oxycodone, hydrocodone, fentanyl, heroin, those are all opiates. And then we have a really big problem in our area with methamphetamine, which is a stimulant. So that would be the stimulant use disorder. And then alcohol use disorder.
What are you seeing in the trends with respect to statistics, patient population having substance use disorders, but either in your region or across the Commonwealth?
I think we've seen an increase in stimulant use disorder, so in methamphetamine in particular in the area. As I wonder, as a result of the opioid epidemic, we've heard from patients that opioids may be harder and harder to obtain. Doctors may have tightened up and aren't prescribing. So as a result, folks are looking for something else. And so we hear that from patients. If I can't find Oxy on the street, then I'll use methamphetamine because that will help me while I'm experiencing some withdrawals or helps with some of those cravings.
And consistent, Kyle, with the national trend, we're seeing a lot of fentanyl appearing in either methamphetamine or even marijuana that people buy. We're seeing it turn up in almost everything now and a lot of it has to do, as Whitney said, is what's available on the street. And then it also boils down to expense. Opiates are based on a plant. So it has to start with an opium poppy, and that kind of limits production. Whereas fentanyl is just a series. They can get these big barrels of chemicals and just mix them in a makeshift lab. So it doesn't really require as much. And so it's available for a lot less money.
Mm-hmm. Why don't you tell us a little bit about, as we're talking about medication assisted treatment, Tell us a little bit about the medications that are used to treat the conditions that you've identified as kind of the most prevalent, and what are the primary types of disorders that they treat?
So the ones that are specifically targeted to opiates include one medication that acts just like opiates act, and that's methadone. And then there's another one that acts kind of like it. One is a full agonist. The methadone is a full agonist. And then there's things called partial agonists, which act a little bit like, or they act like opiates in one way, but not in all ways. And that's the one that we use probably 98% of the time, and that's buprenorphine. Its trade name is Suboxone or Subutex. That's really specifically designed to address cravings from opioids. There are other medications that we use to decrease cravings that really don't work. They aren't nearly as targeted to particular cravings, but medication like naltrexone, which we use sometimes for alcohol use disorder, it doesn't work nearly as well, and it isn't targeted specifically to alcohol.
So how exactly do those medications work? Are they neurological, or how do they reduce kind of the experience that someone might have with the drug or the substance?
Yes. So all narcotics act through receptors in the brain. So if you imagine a little antenna sitting on the surface of your brain that has on the receiving end a very specific shape, it might ignore things that float by that don't have that shape, but once something that comes by that does have the same corresponding shape to the antenna, it locks in. And then it triggers a set of reactions inside the cells of your brain. That's what a narcotic receptor is, like the antenna. And the narcotics that float around through the brain land in that receptor and then trigger either euphoria or pain relief or whatever it is the narcotic is going to do. In the case of a partial agonist, it locks onto the receptor really tightly, but that doesn't trigger all of the same downstream effects. So it can alleviate the craving that empty receptor creates without producing euphoria. So, for example, someone on buprenorphine can take their medication in the morning and then go to work operating, heavy equipment without any decline in alertness.
Can you speak to a little bit to how the treatment and recovery program at your community health center differs from, say, Alcoholics Anonymous program, or someone who just says, I want to try to quit this cold turkey without assistance?
Sure. So our treatment here, we really kind of explain it as a three-legged stool. So you have your medical professional who may be working with the patient. And if that patient is appropriate for Suboxone treatment or buprenorphine, they would work with the medical provider in that treatment regard. Now, you also have a behavioral health team made up of licensed professionals who not only do an assessment and a diagnostic assessment, but can work with that person in individual therapy and group counseling. So in those spaces, folks are really kind of diving into some of the underlying conditions, whether that be trauma, depression, because oftentimes we see substance use as a result of an attempt to cope with other diagnoses, other conditions, life circumstances. Now, in addition to the behavioral health piece, we offer care coordination. And so those are folks here in our office that meet with our patients and help them get connected with community resources. So it's really hard to focus on recovery if you don't have a roof over your head, or if there's food scarcity, or you can't get to your appointment to engage in treatment. And so care coordination is a team of ladies who help the patients really finding resources so they can fully engage in treatment. And then finally, so I guess we're adding a fourth leg, we have a team of peer recovery specialists. And so they are folks who have their own lived experience with addiction and recovery. They're certified by the state, and they use that experience to really meet the patient where they're at and provide additional support as someone who's been there.
So, Kyle, what the Community Health Center allows us to do is to meet people, as Whitney points out, meet people where they are. So we have some people that have been successful in long-term recovery that continue to take the medication, much as someone with high blood pressure continues to take theirs. I check in with them maybe every 3 months. But these are folks that are working full-time jobs, their families are intact. But then we have people that are brand new to recovery that really require weekly visits and then outreach from either our peer recovery specialists or care coordinators or Whitney. They might need some contact almost every day. But because of the way the community health centers that model, we are so accustomed to identifying people's physical need and emotional needs that it really comes natural. It's kind of in our blood to look at the whole person.
Yeah, I think you all hit the nail on the head about the mission of our FQHCs, and particularly here in Virginia, on focusing on the whole person and a holistic treatment model that really helps to resolve perhaps the substance use disorder, but perhaps any underlying conditions that might lead to someone to abuse those substances. So I think that's just really profound, and I think a great and wonderful approach. Can you talk a little bit about kind of a comprehensive harm reduction strategy and how your program plays into that?
So in addiction circles, we use harm reduction as a way of describing a family of interventions that are offered to people who are going to continue to use. So it starts with the acceptance that a just say no approach is not going to work, that in spite of offering everything that we can offer, there will be people that continue to use. Recognizing that these harm reduction interventions are designed to reduce the likelihood that someone is going to die of their condition. So the harm reduction can be a safe place for people to dispose of needles, to keep them off the streets, out of playgrounds and parks. A place where someone can take a used needle and get a new needle so that they're not sharing used needles, which is a source of hepatitis, HIV, and infection that can land people in the hospital. Probably the most advanced form of harm reduction is providing safe spaces for people to use. Now, I don't know, we certainly don't have anything like that around here, but the health department within Montgomery County is starting to work on an initiative that would give a safe place for people to bring used needles and get clean needles.
Yeah, I know that was something that the Commonwealth allowed for localities to determine whether that was a model they wanted to have in their localities on a case-by-case basis. So it'll be interesting to see which counties adopt that and how that might play into the overall effectiveness of these harm reduction strategies. Mm-hmm. Can you speak a little bit about how in your program you may reduce stigma or the shame or guilt of seeking treatment, and kind of what role guilt or shame might play in patients perhaps seeking or not seeking assistance with a substance use disorder?
So we see a lot of guilt and shame, and that's actually a topic that comes up every couple of months in our treatment groups that we provide here. And so patients, I think first starting with the psychoeducational piece, that, guilt is this idea that folks feel badly about an action they had taken in the past, feel bad about something, maybe someone they've harmed previously. But shame is feeling bad about who they are, feeling bad about their being. And so we bring folks in and really try to address that shame, because shame keeps you stuck. Shame keeps our patients stuck. And so working through some of those feelings. So again, kind of taking it back to, we see a high correlation with like trauma and folks that have experienced past traumatic events, how that way of those experiences have led to a certain way of thinking, and how those thoughts lead to how we feel about ourselves. And so for a lot of our folks, shame is that feeling identified.
And I don't know that it isn't typically something that our patients lead with. There's a trial period that I found where people are trying to get a sense of what kind of person, what kind of a program are we running, because almost everybody that comes to see us has got list as long as your arm of bad interactions they've had in healthcare settings. Going to an emergency room with a legitimate injury, someone sees that Suboxone is on the medication list, and then there's this immediate assumption that's, oh, okay, I got this. This person's here because they're drug seeking. We had a patient who was complaining of back pain and was discharged from a bunch of emergency rooms before one of our medical providers ordered an MRI and found out that he had an infection in his spine. So he was in the hospital for 3 months on IV antibiotics. Everybody has experiences like that. So they tend to come into treatment pretty guarded and then over time open up. But I've never met, none of our patients are completely free of regret and guilt and shame to think about the ways they weren't there for their children, times they weren't there for when their parents really could have used their help. And so in processing relapse, which is almost inevitable in the process of getting better, a big part of what we do is to say, look, own this mistake, but identify it as a mistake, and let's see what we can learn from it. What was going on at the time? What sort of set the table for this? Because guilt and shame are not motivators to keep people from using. If that were the case, no one would ever have a substance use disorder. It's important that people own it, understand it, learn from it, and then let it go, because that kind of guilt and shame makes relapse more likely instead of less.
Coming back to this idea of stigma and, so really just meeting patients where they're at to provide good patient care means to really care for your patients. And so, not just looking at their list of diagnoses or looking at them as, well, what's wrong with you, right? It's what happened to you, and trying to understand, again, just meeting them where they're at. I think we see I think there's buy-in from the patients once they recognize that they're in a place that they are genuinely cared for.
So we had one of our patients said to me in one of the visits, you don't care how much they know once you know how much they care.
Wow. I just, as I'm listening to the stories, I feel like when we're talking about medication assisted treatment, like the assisted part of that is really highlighted for me in the community healthcare model. It's, as you both mentioned a number of times, it's a whole person approach. It's not the acute addiction, but really looking at the person and really looking at how can we treat this whole person. And we're not going to judge. We're not going to shame you. We're going to help you get better the best we can. And I think that's really, really powerful. I'd love to talk a little bit more about your program specifically. Many of our community health centers here in Virginia don't have a program like this. Can you tell us a little bit about when you began offering treatment for substance use disorder and what the process for setting up this medication-assisted treatment program looks like?
Whitney was at a recent seminar, and I'd like to have her share with you the numbers just to provide context for the importance of offering this service.
Mm. So there's a huge treatment gap. The treatment gap is 87%. So meaning that only 13% of Americans who have a substance use disorder, an opioid use disorder specifically, managed to get care in the last year. The United States lost a record of 109,000 people due to drug overdose last year. And over 1 million Americans have lost their lives due to overdose since OxyContin launched. And so when we're really looking at the reasons for, starting a program like ours, well, the statistics, right? Those numbers are evident. And so we certainly are seeing similar trends here in the New River Valley.
So that was pretty much provided the impetus. We did a community needs assessment because we weren't offering addiction treatment here either. And I think it you have to recognize that the patient population that we serve brings with them a pretty wide array of need, all the way from housing, how do I fill out a job application, interaction with law enforcement, because that is really, really common. And so I think there is a reluctance sometimes for providers to kind of dip their toes in that world because it does require some extra resources. But once we identified the need, it became clear that more than virtually any other practice setting, we are uniquely qualified to meet that need. The physical need, the behavioral health, our integration has always been very close in the clinic. And when you think about development, well, a lot of our patients have been actively using substances since the ages of 13 or 14, many of whom introduced to substances by parents or close relatives. But while all of us were learning healthy interacting patterns, things that are functional, how do you deal with disappointment without anger or without needing to have it medicated, a lot of people just never learned those things. So among the things I am most proud of is the work that Whitney and her colleagues do primarily in a group setting, but then in an individual setting. Group is a really important part of people learning that they are not, their situations are not unique to them. Their guilt and their shame is shared by lots of other people. And when it's brought out, it can be discussed and it can be processed. And then folks can learn, more adaptive ways of interacting without having to reach for a substance.
Well, to know that they're not alone in those feelings, that I think provides a lot of encouragement and that unity that they feel, and then being able to find solutions with that same group of people. And so, hey guys, I experienced X, Y, and Z this week and I had a really hard time. I realized that, maybe this was triggering for me. And so then other patients can then jump in and say, well, hey, have you thought about it from this perspective? Or, yeah, man, I feel you, the same thing happened to me and here's how I dealt with it. And I think there's a lot of power in that.
Yeah, absolutely. And I think kind of having that shared experience with other people, knowing you're not alone, I think is just sounds like such an important part of that process. Can you describe a little bit more about your program in terms of from kind of intake to, I don't know how you refer to it, graduation, or, kind of what that process looks like?
Absolutely. So folks call our office, they reach out, they find out that they're interested in addiction treatment here. So we have one of our care coordinators who is responsible for completing a pre-screen with patients. So she'll call them up, talk to them about the services that they're interested in, and then if appropriate, get them on the schedule. So an intake day for a patient looks like they will come in and meet with me or one of our other behavioral health providers, and they'll do a full diagnostic assessment. Now, within that assessment, we also include an interview using the ASAM criteria. So ASAM stands for the American Society of Addiction Medicine. And there are questions that encourage us to look at a person entirely, as a person living in their environment, not just looking at their substance use history specifically. After the intake assessment, then they follow up and meet with Dr. Roberts or one of our other waivered providers here at the clinic. And Dr. Roberts, I don't know if you want to talk a little bit about that first appointment with you, what that looks like.
Sure. So as Whitney points out, there are identifiable criteria, and this kind of speaks a little bit to the terminology that we briefly talked about earlier. There are diagnostic criteria which we apply to someone's behavior surrounding the substance. So there are basically 11 questions that I ask, and then based on how many of those are answered with a yes or a no, we can get a sense of how severely they were impacted by their substance use. So physical dependence, there's some terminology that physical dependence means that if you go without your substance, you're going to have some kind of physical symptoms. So it's common, I think, for people to get caffeine headaches. So if you are used to having a few cups of coffee in the morning, and you've been sick and you've been thrown up for a couple of days, you're going to get a screamer of a headache. That's caffeine withdrawal.
Yeah, guilty of that.
Most people can identify with that. So the physical dependence or the presence of withdrawal symptoms, that's one of the criteria that said, okay, this person has used opioids often enough that in their absence, they're going to experience this withdrawal. But more importantly, these questions look for evidence of continued use in spite of the substance causing serious problems in their life. So it looks at, like, have you ever had important work responsibility that you failed to meet because of substance, either because you were high or because you were recovering or you were withdrawing or you were out driving around trying to find some oxycodones? Did it create interpersonal relationship issues? Have you failed to meet family obligations? So we go through these 11 things, and based on the number of answers, if it's more than 6, then they have a severe substance use disorder. So the use disorder goes way beyond, are they using the substance? It looks at what is the impact of it, and have they continued to use in spite of very clear evidence that it's hurting them. So that's kind of what we go into at that first visit with me. And then we do a brief physical exam and then some blood work, because a lot of hepatitis, for example, can be transmitted through sharing needles or through sharing straws. So a lot of even folks that don't inject their pills, that they can crush them and snort them. But if they do that with other people sharing straws, that can transmit hepatitis C as well. So we do a panel of blood work to get a physical baseline as well.
That's great. So I'd love to hear about some of the stories or the impact that maybe you all have observed, and maybe something that stands out to you as a really, maybe perhaps a challenging case, but realized at the end of it that you all are really making a profound difference in your community.
So I have one patient that always comes to mind when a question similar to this is asked. And so we had a patient come to us. She was not originally from the area, but had moved here. So really changing her people, places, and things, moved here to kind of start over, start fresh. Had heard of us and, went through the intake process. She had been substance free for 10 days. And that was the longest she had not used in, I want to say 7 or 8 years. Anyway, wasn't quite sure what recovery would look like for her. So she joined the program, engaged with us, hung in there, continued to meet with us weekly. Really, some weeks, most weeks in the beginning, she had 2 appointments each week because she was doing group therapy, meeting with Dr. Roberts, and then meeting with me for individual sessions as well. She has demonstrated so much success, adherence with her treatment plan, working towards treatment goals, increasing like her relationships. So she didn't previously have any communication with her children. So 2 children, 2 adult children, and 3 little grandchildren. And it had been a number of years since she had really had any kind of intimate relationship with any of her family. And 2 of her grandchildren she hadn't even met yet. So today she's progressed through the program, moving from weekly visits to bi-weekly visits, out to monthly visits. She has over a year of demonstrated success in recovery, and actually has started to work as a peer recovery specialist at another agency in the community. And so using her success and her lived experience in recovery to then kind of pass it forward and help others.
That's really incredible. It's just a
Kyle,
fantastic story.
What's really cool for me is I get to sit in on some parts of the group and to listen to some of our patients kind of helping their peers through a problem, through skills that they've obtained in the program. And then to watch someone who may have been unhoused find a place to live, find work, get transportation, reestablish communication with family. We've seen it. We've seen people put their life back together kind of brick by brick. And our peers are a really phenomenal example to the rest of the people that come into the program, because one of them in particular, we did in Blacksburg, there's an osteopathic medical school, the VIA College of Osteopathic Medicine. They invited our peers. I went just as the doctor person, but 90% of the thing was just listening to the peers tell their story to the medical students. To listen to her story reminds me of just how exceptional those two are and where they were, jail, IV substance use. And now they're paying it forward. They're using their experience to act as a living role model to say, hey, this can be done. And I actually did it. And I was right exactly where you are today.
So actually just last week in group, so every week I have, a couple of questions we ask for check-in and then like an icebreaker question. And so that changes from week to week. And usually it's a little bit of a fun question. So the question last week was, who is your superhero and why? And everyone went around the table and most patients mentioned someone like Batman or
all
Superman.
The men said Superman.
Yes. Then we get to the last patient and he mentions that the peer sitting at the table is his superhero because she has figured out recovery. And if she can figure it out, despite all of the things that she's experienced in her life, that's what he wants. And so really kind of looking to her as a role model.
I mean, that is amazing. I mean,
so heartwarming.
That's so heartwarming. And
yes.
Really that you couldn't have better, advertisement for the program if people are seeing from their peers, from their friends that they were going through something so difficult and could emerge, in a better place. I mean, what greater success story could you point to? I mean, it's truly amazing. And you can just hear and see the passion from you all and what you do. And, it's really amazing and remarkable work.
Thank you.
What advice would you give to community health centers who would like to follow your example and set up a treatment program at their community health centers? Any pitfalls or challenges that you observe or advice you could give them?
So the first, I think, would be to recognize that for anybody who thinks they don't have people that could benefit from that service in their practice, they say, if you think you're not seeing substance use in your practice, I guarantee you it's seeing you. So recognize that there are people out there that you can serve. Mm-hmm. You can start in a very simply, because a lot of the patients that come to the community health center are getting their medication-assisted treatment elsewhere. Mm-hmm. So to be able to bring those people into the fold and say, look, I love all of you. I don't want just to take care of your high blood pressure and your diabetes. I want your substance use disorder too. That communicates a sense of acceptance and basically kinship. That's really what we go for, is to say, look, you're not any different than me. And there's nothing about this that, makes you off limits to me. And I'm willing to take that in too. So you could start easy. Just assume the prescribing for the medications that your patient may already be going elsewhere to obtain. That'll give you a pretty good idea of what the kinds of detailed in and out are like. What kind of relationship do you have to have with the pharmacy? Because unlike blood pressure medication, if someone goes a day or two without their medication, they're going to withdraw. That's a very big deal to maintain that you a very good relationship with the pharmacy where you're sending the prescriptions and understanding how to use there's a nationwide database of prescriptions that you can tap into to find out exactly when someone got their last prescription. So making a start like that, and then if your heart is open to the care of all of the stuff that people bring in the door with them, then I really do believe it'll lead you to a fuller and a more robust program. And I mean, we all have great relationships with our behavioral health specialists in the clinic. You can tap into that because I guarantee you that someone is going to have a heart for this kind of work.
And what we're doing here isn't necessarily groundbreaking or taboo. Medication-assisted treatment is recognized as the gold standard of care by the World Health Organization, by the CDC. And as Dr. Roberts mentioned, we're already serving those folks who are struggling with a substance use disorder. By now including the treatment of their substance use disorder, we're now just integrating healthcare further. We're providing a more comprehensive level of care, fully addressing the needs of the whole person.
Well, that's fantastic. With that, I just want to ask, do you have any final thoughts or any areas that or topics that we didn't cover today that you'd like for the listeners to know about?
I'd like to just point out the kind of indirect benefit of getting someone into treatment. So the medication itself reduces the risk of overdose death by nearly half. But the involvement with the community health center also allows us to start addressing physical need, because a lot of folks come in having completely neglected their teeth, for example. To see somebody regain the ability to smile without always feeling like they have to put their hand over their mouth when they're about to smile because they're so ashamed of what has happened to their teeth over the past 10 years. All of those things further integrate them and make them feel more like they belong and that they're less kind of stigmatized, less other. So there are those indirect benefits which are much more difficult to measure, but are very, very easy for me and for Whitney to see on a day-to-day basis.
Well, and there are statistics that show us that every dollar spent on treatment can actually save $12 or more on criminal justice and healthcare costs. And so, it is a public health. There's been a huge impact to the public health. And so if this is one small thing that we can do to address such an issue on a large scale, and again, looking at the number of people that have died from drug overdose, I think it's nice for us to think or for people to believe that abstinence only is the way to go. But, just frankly, that's not realistic for everyone. And people can't recover if they're not here. And so harm reduction, if we're keeping them alive, well, then we're increasing the opportunity for them to, go on to have meaningful relationships and meaningful lives and, connect in society in a positive way.
And I would be happy to talk to anybody, Kyle. I'm happy to put my email and even my cell phone. Anybody in the community health center that is thinking about doing this or first steps, I would really love that opportunity.
Well, we'll make sure they have that information because you both are a tremendous resource, and this would be a fantastic model to replicate and expand throughout the Commonwealth to really address this public health crisis. So thank you so much, Ms. Petrie, Dr. Roberts. Thank you so much for your time today. I really appreciate it, and you all have a wonderful, wonderful day. I'd like to thank our guests for joining us today, and thank you to all our listeners for tuning in to Common Health, brought to you by the Virginia Community Healthcare Association. If you enjoyed this episode and you'd like to help support Common Health, I encourage you to hit the subscribe button, share it with others on social media, leave a rating and review, or visit our website at www.vcha.org. This is Kyle Elliott, and thanks again, and we'll see you next time.